Hello, everybody. Happy Friday. Welcome to a special session today hosted by Cami and Texas A&M School of Public Health. Today's presentation is, as you can see, is going to be based on the Rural Healthy People 2030 publication, who was written by a lot of the faculty at Texas A&M University. I will pop a link into the chat after my quick introduction here, so you're able to reference the publication either during the call as they're going through some of the themes and topics, or after the call. It's a really, really great research study, and I highly recommend taking a look at it. So today we're excited to explore the findings and recommendations from the comprehensive report, which focuses on improving health outcomes in rural communities across the United States. The research study discusses key health challenges faced by rural populations and highlights actionable strategies to help address these issues. It emphasizes the importance of tailored approaches that consider the unique social, economic, and environmental factors impacting rural health. And it helps inspire in collaborative efforts to enhance the well-being in these often overlooked areas. So today we're going to take a listen in to learn how we can work together to create healthier rural communities. So to help us do that, today we're happy to have Dr. Alva Ferdinand and Dr. Murray Cote from the Texas A&M School of Public Health. And I'm going to pass it over to them. I don't want to speak on their behalf, on their current roles and all the things that they do that are so great. So I'm going to pass it over to them to begin the presentation and introduce a little bit more about themselves and what they're currently doing.
And howdy, everybody, while we get our slides loaded. It is nice to spend some time with you this afternoon.
Again, thank you to Melissa and to Anthony and Eric for hosting us, and we're looking forward to this presentation this afternoon. I'm going to be sharing the screens. I understand Anthony is going to be monitoring the chat, so if you have questions as we begin, and then Alva and I will sort of iterate between the topic areas with it. And again, we thank you for attending.
Well, howdy again, everybody. I am Alva Ferdinand. I am an associate professor and department head of health policy and management at Texas A&M. And I also direct the Southwest Rural Health Research Center, which I'll speak a bit more about in a few moments. And Murray, you want to introduce yourself?
Yes. Good afternoon, everyone, and howdy. If you understand Texas A&M, you'll know howdy. I'm Murray Cote. I'm an associate professor and the director of our PhD program in health services research in the Department of Health Policy and Management at our School of Public Health.
So let's chat a little bit about the center and our funding source. If we go to the next slide. Perfect. So we are the Southwest Rural Health Research Center. Again, we've been funded by the Federal Office of Rural Health Policy for quite some time. The center was one of the first centers established at Texas A&M. And for this particular work that we'll be talking about today, Rural Healthy People 2030, the survey that helped to inform the work was funded by the Federal Office of Rural Health Policy, which is in the Health Resources and Services Administration, or HRSA, within the Health and Human Services, U.S. Department of Health and Human Services. So we have a cooperative agreement with them, and we've recently been refunded for another 4 years. And the volume that I'll be speaking about, Murray and I will be speaking about, was funded by the Texas A&M Health Science Center. So this work was funded by two sources. And everything that we say should be attributed to us and not to the Federal Office of Rural Health Policy or the Health Science Center, etc. Neither Murray nor I have any conflicts of interest to disclose. So I'm sure most of us, if not all of us, are familiar with the Healthy People Initiative, but just in case we need a bit of a refresher, Healthy People is an initiative that was envisioned by Health and Human Services through the Office of Disease Prevention and Health Promotion. And since 1980, the Healthy People Initiative has been setting measurable objectives on a decade-by-decade basis to improve the health and well-being of residents of the United States. And the basic idea is to have experts come together in various health fields to talk about what they're seeing on the ground. So this might include clinicians, researchers, folks that work in health departments, etc., and get together and set goals for improvement that we can then track over a given decade. And this initiative really gives us a way to strive towards certain benchmarks and goals in an effort to improve health. So, Healthy People 2030 was launched in 2020 and is meant to guide us within this current decade. So, how do we get started with rural healthy people? This is really a play off of the Healthy People initiative. And the work of rural healthy people was originally commissioned by the Office of Rural Health Policy in 2002. It's now called the Federal Office of Rural Health Policy. And the impetus behind it was it wasn't clear that rural health was being taken into consideration in this initiative, and rural voices were perhaps not being included. So, Rural Healthy People 2010 was the first time we engaged in this work. I was not yet at Texas A&M University, but Rural Healthy People 2010 served as a companion to Healthy People. And it was the first ever piece of work that was specific to rural in light of the Healthy People objectives. And the way in which the director at the time went about doing this, the director was Dr. Larry Gamm, who's a political scientist. They did focus groups around the country. And so they traveled to various parts of the country and asked rural stakeholders, what are some of the things that are rising to the top for you that you're seeing as being really, really, really critical to helping rural populations in their endeavor to be healthier? And so, Rural Healthy People 2010 helped to identify priorities for uh, um, rural populations in their attempts to achieve progress. So I want you to really take a look at this list because this list is going to evolve over time. So I'm starting with 2010 so that we build up to 2030. And what we see here is there are several tied positions, right? So access to quality healthcare being number one. And again, this was for Rural Healthy People 2010. And then heart disease, diabetes tying in second, mental health and mental disorders in fourth place. And then take a look at tobacco use, substance use, all sort of hanging around in the sixth position. And then nutrition and overweight status in concert with cancer, public health infrastructure coming in 10th. So remember this as we continue on to subsequent years. Okay, next slide, Mary. So this takes us then to Healthy People 2020. And instead of doing focus groups, we sort of made use of technology. Again, I wasn't here just yet when the survey was launched. But instead of focus groups, we launched a national survey and really tried to identify rural stakeholders to get their take on what the most critical Healthy People objectives were for rural America. And in this work, we identified and cataloged what worked in rural America, what had promise, and this was all based on evidence from the previous decade. And we really went about disseminating this work to local, state, and federal policymakers and really used it to prompt some discussions on what to measure, how do we measure it, and what strategies can we put in place to improve population health in rural America. So 2020, the work included an initial survey that was fielded, and we got 755 respondents. And the director at the time, Dr. Jane Bolin, wasn't quite happy with that number. And so a webinar was conducted, which was sponsored by the National Organization of State Offices of Rural Health, or NOSOR, and several letters were sent to state health officers and others. And the response that we got was significant. So there was a bit of an improvement in the sample size. So we had 1,214 respondents to the Rural Healthy People 2020 survey. And now I want you to take a look at these objectives. So again, this is 2020. And we see access to quality care still hanging out in the first position. But then look at nutrition and weight status. That moved up significantly in our thinking about the 2020 benchmarks that we'd want to achieve. And I think, as I reflect on my time in graduate school, we were really thinking about childhood obesity at the time, adult obesity, thinking about what programs do we need to put in place, what policies do we need to put in place. And that was something we tackled quite aggressively. So I want you to also remember where this lies for 2020 in relation to 2030. So the way in which we disseminated the 2020 work was we put them in two volumes. The first 10 priorities went into volume one, and the priorities 11 to 20 went into volume two. And you can see those listed here, and the websites are listed as well. And we launched these in 2015. All right, so that takes us to the next slide. So we get to 2030, which is our current iteration of Healthy People. And it is the fifth iteration of Healthy People, launched in August of 2020. And I have to tell you, we weren't sure that this thing was going to be released. Remember that we were, in the height of a pandemic at the time, and we were sort of, waiting with bated breath. The center was on, is this going to be released or not? What does it look like? Dr. Bolin and I had the opportunity to participate in the diabetes working group. So we were familiar with what was coming in terms of objectives for diabetes. But we did see the launch of Healthy People 2030 in August 2020, and it once again focused on national objectives to address the nation's top public health priorities. And there was a focus on fewer objectives and higher data standards. So, what were some of the biggest differences between Healthy People 2020 and Healthy People 2030? There were fewer Healthy People objectives, but the number of overall objectives, which is the focus of rural healthy people, increased. So there are now 62 priorities to guide health promotion and disease prevention efforts. And for the first time, Health and Human Services kind of grouped these topics into, or grouped the objectives into 5 topics. So the first topic, health conditions, looking at things like addiction, diabetes, mental health conditions. The second topic being health behaviors, sleep, physical activity, injury prevention, etc. Populations, so older adults, people with disabilities, etc. Settings and systems, so these include schools, transportation, hospitals, emergency services, and then importantly, social determinants of health. Social determinants of health did make an appearance in the Healthy People 2020 initiative, but here in 2030, we really saw social determinants of health really become a topic of its own and includes things like economic stability, education access, built environment, etc. So I'll touch on why this work is still important. In 2020, we were sort of asking ourselves, is this something that we need to continue? This work is something we've been doing every decade since the inception of the Southwest Rural Health Research Center. And so in trying to figure out, is this work still important? That is it still important for us to hear from rural stakeholders on what are the things that really, really need to be worked on in the upcoming decade? And to answer this question, we simply had to look back to some of the work that we'd done previously. So here I sort of highlight a paper that we did that was published in Health Affairs, looking at progress toward healthy people targets for major causes of death. And there was some other work that we did looking specifically at the leading causes of death. We published a chart book, again, funded by the Federal Office of Rural Health Policy. And what I'll do now is turn it over to Dr. Cote, who will sort of go through some of the findings that we disseminated.
Thank you, Alva. Well, folks, I'm going to discuss a little bit more detailed the statistics that Alva alluded to and the particular outcomes that Alva alluded to, pulling from the Health Affairs article. In the next set of charts, What I really want you to pay attention to are the top two lines, the red line and the orange line, and we apologize in advance if the colors aren't coming through as clearly as we'd like them to. The ones that represent small metro and non-core with it, and compare them in contrast to the healthy people target. That's the dashed line in the center of each of the charts with it. These are time series plots, and so the year is provided along the horizontal axis, and then our performance measure, our statistic that we're looking at, is provided on the vertical axis. In general, the direction that we want these targets to be is moving downwards. And as we go through these, again, please pay attention to the small metro line and the non-core line. The idea here is that these are going to be our rural communities that we've been looking at. And this particular slide is age-adjusted overall diabetes mortality rate. And you can see those two series, those two populations, if you will, are the highest of the lines that are comparing. And they're also above the target. We're Healthy People 2021. So hang on to that theme, please. So this is overall age-adjusted diabetes deaths by year. If we switch to age-adjusted heart disease deaths by year, we see general progression of improvement where we didn't really see it in diabetes. It was kind of flat across all of our populations. But again, where you see our small metro and our non-core, the non-core, we refer to that as our rural population. It's improving, but it doesn't improve at the same rate or at the same extent as we see in our other populations. So it's there, it's above our targets. Okay. We look at suicide. Unfortunately, with suicide, not much improvement has been made in terms of this rate across all of our populations, and particularly challenging, if you will, is the rate in the rural populations, again, the non-core time series with it. The age-adjusted cancer deaths, as Alva had alluded to with our colleague, Dr. Jane Boland, progress being made on cancer deaths. But again, the rural is that lagging behind it. It's improving, but it doesn't improve. It gets close to the target, but it's not there just yet. And then moving then back to Alva for Rural Healthy People 2030.
Yeah, so in taking all of those graphs into consideration, and we have so so many more graphs that we had to be respectful of your time and really kind of think about how to package this in the time that we have together today. But it was very clear to us that even though for several of the disease categories we looked at, progress is being made, our rural populations, as Dr. Cote shared, still weren't meeting the benchmark. So it was still important, we determined, still important for us to reach out to stakeholders to find out what are the things that are really percolating to the top, and what are some of the things that we really need to focus on if we are to see real improvements and movement in the needles of the objectives that we are setting forth for Healthy People 2030. So we fielded another survey, and we did this between July 12th, 2021 and February 14th, Valentine's Day 2022. We thought that'd be a good day to wrap things up. And we reached out to stakeholders, and we had a very permissive definition of rural stakeholders. And I will talk about the sample here in a second, some of the things that we've hoped for and wished for. But we deemed rural stakeholders to be individuals who work to improve the lives of and health of rural Americans. And those folks include providers, include folks that work in human services, etc. And I'll show you that breakdown here in a moment. So we had about 1,300 respondents to the survey, and we started the survey with Healthy People objectives, but we also threw in some new questions about, since we were in the midst of COVID, how certain relief dollars were being utilized, etc. by these various organizations. Next slide. So here's just a brief sort of description of how we went about identifying people. So we emailed everyone who had previously downloaded Rural Healthy People 2020, and we have the ability to track that from our website. And we emailed those folks inviting them to participate in the survey. We also engaged in snowball sampling. So we asked those that we'd emailed and received, the commitments from for responding to the survey, who else should we be reaching out to? And then we partnered with various organizations. This is, again, not an exhaustive list, but we partnered with the National Rural Health Association, the American Hospital Association, the Federal Office of Rural Health Policy, CDC, USDA, National Association of County and City Health Officials, and importantly, state offices of rural health to try to help us disseminate the survey. So let's just go ahead and pull all of this up, Murray. I know it's okay. So perfect. So let me just touch on the sample. And we feel whenever we are asked to kind of talk about this work, we feel it very important to talk about the sample because there are things that were a bit troubling to us. So if you look here on the left-hand side, you'll see that most of our sample identified as white. And we felt maybe this isn't particularly representative of rural populations more broadly. And so in going forth in this work, we're actively thinking about how do we reach um, more representative stakeholders and what are some of the groups that we need to tap into. And I can discuss that a bit more. But also we welcome your ideas on who we might be missing. But we did really struggle with the representativeness of the sample with respect to race and ethnic identity. The mean age of our respondents was 46. 64% of our sample had graduate or professional degrees. 77% were female, and then we had about 4.2% of our respondents identifying as Hispanic or Latino. In terms of sectors from which we received responses, healthcare, education, human services, media, housing were all represented, and we had over 100 professions in the sample, including healthcare administrators, physicians, researchers, professors, rural health clinic personnel, etc. So also important for us was to sort of identify where respondents were coming from. And based on rural population size, there were some states that we identified as perhaps we need to oversample in the next iteration of this. So South Carolina, Ohio, Alabama, North Carolina, the ones that are sort of highlighted in orange are the ones that we felt were a bit underrepresented. But we did get responses from all states except Connecticut. And Washington, D.C., we don't particularly consider it to be rural either. So this just gives you a breakdown. And then the pie chart on the right, it gives you a sense of where respondents were located. We had a sizable number of respondents from the South and Midwest at about 33%, 13% from the Northeast, and then 22% from the West. Next.
So thank you, Alva. So sort of coming then full circle, if you will, to the Rural Healthy People 2030 top 20 priorities. And this is based upon, again, this sample of almost 1,300 respondents. You'll notice the top 10 categories where healthcare access and quality was perennially one, if not the top one in previous iterations. Very quickly, or not very quickly, but gradually over time, mental health and mental disorders and addiction became top priorities for our rural communities. Healthcare access and quality, number 3, overweight and obesity, are things that we think about in terms of keeping people healthy in rural communities. The stuff that we hear about in the media for the rural communities this very much reflected in there. And then to a lesser extent, the other parts of access to care, like transportation, cancer had dropped to number 12, the public health infrastructure, housing and homes, workforce and workforce development, our education, our health insurance, child and adolescent care. And for the first time, when we talked about healthcare access and quality, we had separated healthcare access and quality so that we also talked about or asked about hospital and emergency services. Historically, hospital and emergency services have been bundled under healthcare access and quality. And then last, chronic pain. Now, keeping this chart in mind, where Alva had asked me to contribute to Rural Healthy People 2030 had to do with hospital and emergency services, in part based upon the research that I do and the themes of the research that I do. So I'm going to take a sidebar here and under healthcare access and quality, talk about hospital and emergency services and what we found with respect to our chapter in Rural Healthy People 2030. So as we mentioned, it was ranked 19th and it was part of healthcare access and quality category. Now, when we dug into this a little bit deeper, how we viewed this access and quality category under hospital and emergency services, we started with what Healthy People 2030's target was for people getting access to care when they need it. What we found within our communities is that our baseline was 8.5%. It had improved to 7%, but we were still well below our target of 5.9%. And this is kind of reflective of those other figures that we shared from the Health Affairs article, that we're making progress, but we're lagging behind and we're typically above the target that we want to achieve if we're improving, we're moving in the direction of improvement. The Healthy People goal to reduce hospital-based infections was able to meet. We've been really, really good sort of at rural communities and sort of nationally when we approach this and we're paying attention to doing this and doing this well. Now, there's an other side of this, there's many sides to this coin, and sort of the worst side of this coin is that, as we know, between 2015 and 2019, that 59% of our community hospitals that were closed were rural hospitals. This puts incredible strain on the resources available to rural communities. Now, from here, we said, well, what else is there if you have all of this in this context? And so we said, well, the first thing is, well, improving wait time for emergency departments. And part of it is an often behavior that happens within our rural communities that if we need health care, we will seek out our local hospital, and more likely than not, we will go to our local hospital's emergency department if it exists. Well, this sort of has several implications in it. One is, well, what's the waiting time for the emergency department visit? And there isn't really a standard out there. We would like it to be timely. We would like it to be appropriate. And we think about what the Institute of Medicine reported back almost 2 decades ago. I mean, its availability, its capacity, and its diversion with it. But then you add on top of it the rural communities, and we say, well, there could be population density that we have. We know that our rural populations are very sparse. Is there alternative care venues? This is where we would talk about standalone clinics, if possible, or primary care clinics that may be able to take more appropriate arrivals instead of going to the emergency department. And of course, insurance status with it. From the rural communities themselves, and as we saw, not a priority, but it's a matter of fact of where they exist. Resource availability, staffing, and technology, so that they have communities with limited insurance and they're uninsured or underinsured, and of course their willingness to travel. What we've seen recently, by recently within the last decade or so, starting with the High Tech Act of 2009 and then the Inflation Reduction Act from 2022, is that there is a national willingness to say we need more access to technology and health coverage. We want to support our rural hospitals, keep them open. And one of the big pieces in this was the allowance of the conversion of critical access hospitals and the like to what are specified as rural emergency hospitals, so that we can keep emergency departments available in these rural communities. Now, from here, we think about our priorities by region. And I think this is why I turn this over to Alva.
No problem. So yeah, we did a few breakdowns. Again, many more than we will present here in the interest of time. But we were curious as to where stakeholders were prioritizing things and how that differed depending on where those stakeholders were situated. Um, Importantly, though, what we want to note is across the board, so Midwest, Northeast, Southwest, mental health and mental disorders were most frequently identified as the top priorities, as well as addiction coming into the second place. And then when we looked at the third place, that kind of had some variation by census region. So for the Midwest and the West, healthcare access and healthcare access and quality were the things that were, in the third spot for those particular census regions. But then for the South, this was really interesting to us. Overweight and obesity fell into that third spot. And then in the Northeast, it was more about drug and alcohol use. And that kind of really aligned with what we've seen in other research with respect to overdose deaths and struggles with opioid overdoses and those kinds of things. Looking at Medicaid expansion status. So we were curious as to whether priorities would differ depending on whether you were in a jurisdiction that expanded Medicaid or not. And what we saw there was that it didn't matter, that whether you expanded Medicaid or not, mental health and mental disorders, addiction, and healthcare access and quality were tending to be the most frequently identified priority areas. And then we broke this down by race ethnicity. I told you a few moments ago that the sample wasn't as diverse as we would have liked or would have expected. And so we did sort of a white, non-white breakdown. Not much variation here either, except when it came to the third most frequently identified priority. So mental health, mental disorders, and addiction, again, really, really floated to the top for this particular iteration of Rural Healthy People. And then amongst our non-white stakeholders, they really identified nutrition and healthy eating, a frequency that allowed it to be in the third spot. And then we broke this down by field of employment, again, just to see if depending on where you worked, you had a different point of view. Again, we saw mental health and mental disorders being pretty consistent across fields of employment. So whether you were in education, government and public administration, healthcare, human services, or some other type of employment, you identified mental health, mental disorders, and addiction. And there was a bit of variability in terms of the third most frequently identified priority. For education and government and public administration, they identified healthcare access and quality to be most frequent in that third spot. But then if you were in healthcare, you were identifying overweight and obesity more frequently. And then if you were in human services, drug and alcohol use. So a bit of variation for what's most frequently cited in terms of that third spot, but pretty consistent across the board with mental health and addiction. And then by work setting, so we sort of differentiated, where people were. So looking at federally qualified health centers or rural health clinics. Again, pretty consistent story here with mental health and mental disorders and addiction. And you may recall in Rural Healthy People 2010 that mental health disorders, they were in the top 20, but not quite as high. And these, what we've seen in our results for Rural Healthy People 2030 is a pretty alarming sort of identification of mental health and addiction as being what we really need to focus on in this decade. Next. So I talked about the frequencies in the previous slide. So it's sort of looking across the board at the whole sample. What are the priorities that are most frequently cited? This slide, however, we asked people to rank rank your priorities, right? So there's frequency and then there's where it falls. And so what we see here is a bit of a shuffle, but sort of a similar story. And I think it speaks to availability of services for mental health and addiction services. So respondents were asked to rank their priorities in terms of importance. And what we saw come to the top, which was consistent with our previous versions of Rural Healthy People, healthcare access and quality, mental health and mental disorders, and addiction. I'm starting to sound like a broken record, but just so you have a sense of what this looks like. Okay, next. Here are some key takeaways, and we had many insights, but for the third decade in a row, we had survey respondents ranking access to healthcare as the number one public health priority. Selected priorities are often, but are not always consistent across census regions, demographics, industries. So we really feel like this work is important to look at in a stratified manner, so that if you are someone that is working in a particular jurisdiction, you kind of have a sense of what that looks like. But overall, and across all census regions, more respondents included mental health and mental disorders and addiction in their list of top 10 public health priorities than access to care. And while healthcare access remains highly concerning in many rural areas, mental health and substance use disorders have really become even more ubiquitous. So I know Melissa has shared the link in the chat. We are making this resource available to anyone who would like to view it. If you're someone like me, and I think Dr. Sinowski, I saw his hard copy a few moments ago. If you're like us and you want to flip through, you can request a hard copy from us on our website, or you can email Natasha Johnson, who serves as the Assistant Director of the Center, or you can download it for free and read it digitally if that's your preference. I am not a huge social media person, but we do have a social media account, and our students do an amazing job of updating that for us. And feel free to share the resource on your platforms as well. We'd love that, and we'd love to connect in that way. Oh, okay, yes. So the team effort. I guess we've just wanted to touch on the process because earlier we were chit-chatting about how long this took. And it was indeed a heavy lift. So in addition to sort of fielding the survey, we then had to put research teams together to then write the chapters on each of the topics identified in the priority areas. So we had 20 total chapters and research teams. And each of these research teams did very extensive searches of the peer-reviewed and great literature. We worked very closely with our librarians here at Texas A&M University, who are absolutely amazing. We had over 65 authors on chapters representing universities, including Texas A&M, Boston University, the University of Central Florida, East Carolina University, the University of Alabama at Birmingham, which is my alma mater, and the University of South Carolina. We really tried to identify subject matter experts to contribute to each of these chapters. And we were really proud that our authors represented a variety of fields, including public health, nursing, medicine, political science, etc. Off
The
to you, Dr.
last part of our slides, the last part of our presentation, and thinking about when Melissa and Anthony and Eric charged us with this opportunity, is also to take it back to CAMI and to the programs, the graduate programs that are accredited by CAMI that are helping shape our future healthcare leaders. So when we reflected back upon Rural Healthy People 2030, and you look at their priorities and the way Alva has seen them evolve and how she discussed how they evolve, that first 10 are kind of like, how do we take care of patients? And that next 10 are, what are those resources that we have available for us? And so we think that's actually an ideal sort of starting point for us to potentially discuss and introduce our rural communities into graduate health management education programs and for future health services leaders. So, I mean, a couple of things that we know is that there's a dearth of invested healthcare leadership in rural communities. It's hard. It's hard to find people to manage healthcare, rural healthcare facilities with it. It's a challenge. Not often, and we see this across graduate programs, do our students say, I want to go to rural healthcare and I want to be a rural hospital administrator. It's just not thought of as an early careerist. We're fortunate at Texas A&M because we typically have 1 or 2 students per cohort that say, I like that because that's the community I'm coming from. So we're fortunate in that regard. If rural healthcare is discussed in a graduate healthcare program, it's kind of a sidebar. It doesn't quite have the cachet of, urban settings or major metropolitan settings. But if we think about this in the context of what Alva and I have shared with you this afternoon, I mean, there's an opportunity here in these communities to see so much so quickly. These are amazing challenges and opportunities that are incredibly pervasive. So we can think about how do we make healthcare delivery better through operational improvements. So things that come to mind right away are things like how do we do more in terms of care coordination, case management, care coordination, and discharge planning, so our communities learn how to use the healthcare facilities and resources that are available to them. And then, as we've seen at the federal initiatives, is get better access. And by access, we really mean technology, we mean health insurance, especially network adequacy, and in helping our communities learn how to navigate the healthcare system. And those exist also in the other than rural areas, but they're so intense in our rural communities. And then, so as I alluded to, of course, on this slide, the same as the urban communities, but more intense, different importance and available of resources. They just don't have the benefit of a Houston, a Dallas, a San Antonio with it. Urban settings, then when we think about that and how do we sell it, if you will, and I don't think that's the right phrase, but the urban settings become providers for rural residents, especially with specialty care, because we won't see specialty care provided in the rural communities. And then we think about ourselves in terms of academics and how we serve and how we better understand and how we study rural healthcare. The health services funding agencies, so HRSA and NCI, they're now requiring rural outreach components as part of their application process. So it's nice that we're paying more attention to it. It's nice that we've provided additional focus on it. Our work is not done with it. And we're looking forward to Rural Healthy People 2040 sometime in the future. All right. And on that note, on behalf of Alva and I and Natasha Johnson, who's been just our incredible helpful resource in Rural Healthy People 2030. Thank you so much for your time, folks. Again, thank you to Melissa, Anthony, and Eric for arranging this talk, and we'll open it to questions.
Mary, thank you very much for the call, and Alva, just appreciate both of you being on and going through it. I did get my copy of Rural Healthy People 2030, and I remember when it arrived, being a geeky person, I picked it up and I did read it cover to cover. Just an amazing piece of work, and I'd recommend anyone out there who's really interested in the health community to get a copy of it. It's an exceptional piece of work, a really good piece of work. I love how you brought it home to graduate healthcare management education. How do you convince students to kind of move into a rural community? And at one point in my career, I had ran a fellowship program with Aramark, and we had the hardest time finding a student to do a fellowship at one of the rural healthcare systems that Aramark had served at that point, even though they were building a brand new hospital. Everyone wants to go to Cleveland Clinic and Advocate and Henry Ford, but it's a good point of encouragement to make, and thank you for doing that. My question to you, and anyone who has questions, please kind of designate in the chat. So let me talk a little bit while we get some of those questions kind of pulled together. But the part that was incredibly disheartening to me was mental health being #1 on the list. And then if you look at the others that are down there, addiction and drug abuse and alcohol abuse, certainly even, and not to kind of say all obesity is related to mental health, it certainly isn't. And I'm not saying that, but there's certainly a component around overeating that's sometimes related to mental health issues. You compare prior times to this time, what changed? What moved mental health up? What really kind of accelerated?
Murray, do you want me to take that one? I think we can't forget when this study was fielded. We were in the height of the pandemic, so 2021, and we were all sort of sitting sitting at home in very isolated fashion. And I think we were coming to terms with, you know, this idea of despair, what's going to happen. Folks were losing relatives and friends and loved ones left and right every time you turned on the news. There were lots of things to not be mentally well over. But I also think that as time has progressed, we have been doing a better job with diagnosis, calling a thing. And whereas in previous years and decades, we were much more tight-lipped about mental health and mental disorders. I think it's something that we are getting more comfortable speaking about. And this is also true for rural communities. When we did Rural Healthy People 2020, I was a brand new faculty member here at Texas A&M, and I was in charge of the mental health, mental disorders chapter, which was in the list, but not quite at the top. And there was, I remember at the time, a lot of research on stigma and how rural individuals deal with mental health access, which was to mostly not deal with it and to sort of keep it to yourself, because in rural settings, you don't really want that news to go out that perhaps there's something going on. But I think as I have studied that literature over time, and just in looking at our survey results, I think some of that stigma is beginning to kind of melt away. I think there's a lot more work to do, but I think we're talking more about it in schools, and our school counselors are more aware of it, and we're seeking out those resources. Telehealth is also helping us to be able to access um, treatment and care for mental health, mental disorders in a higher degree of accessibility than before. So I think there are a number of reasons, and I think those might be a few of them. And I don't know, Murray, if you have anything coming to your mind that I
I
can't
think
mention.
so, Anthony. And again, it's sort of like the pandemic sort of peeled a lot of layers back of things that we didn't discuss or didn't think we needed to discuss. And in the rural communities, I think they were especially vulnerable to how the pandemic played out, because not only are we isolated, and now we're kind of scared because what we're hearing about the pandemic, and then what may happen if one of our loved ones gets infected with COVID, they get brought to an urban area and we can't see them with it.
Mm.
So there's that thing. But then on the flip side, and as Alva shared with it too, if there's an upside, it's that we realize that we can also deliver health services by telehealth, where we were sort of nipping at the edges of telehealth. The pandemic sort of kicked that door open, and we can't put that back in. There are communities that really rely on telehealth, and that the technology out there is actually quite good. So in terms of access, we have it. So it's sort of like we recognize there's a greater need for different types of health services, especially these things related to addiction, however broadly defined. But then we have the technology that says, all right, let's be able to deliver it. The piece that's missing is those providers. How much resources can we provide for them to ensure access to that, so that we know that our measures are moving in the right direction? Can we move them in the right direction quicker so that they're comparable with other communities?
Yeah, there was a concept Martin Seligman talked about, learned helplessness, back in the 1980s, and what you're basically describing is a process in which learned helplessness became so much significant more because of the pandemic. Excellent. I know Norm Tessel's got a question. Norm, who's kind of served a variety of different roles in terms of technology and healthcare systems and the like. Norm, go ahead, it's yours.
I noticed in the survey a lot of it was done with individuals who are stakeholders within a certain area of work or age or race. And as I mentioned, I might have missed it, but do you go back to the patients themselves as a segment? I was thinking specifically about senior citizens because their interests might not be as specialized as the ones that you had, but equally impactful, such as access and end of life and retirement, or those types of availability of post hospitalization, such as treatment facilities or assisted living and those types of areas. Um, is that an area that would end up in your type of survey, or is that something that you're only focusing on other groups?
Yeah, so we did not survey patients themselves in this work. I think you're absolutely correct. That probably would have taken on a whole different set of findings, especially if we stratified by age cohort. We did have a pretty, I don't, what's considered middle age? Our average age,
It depends on how old you are.
right? Yeah. So, yeah, our average age was 46, which I guess is middle
Well,
age-ish.
it's usually the people who are older than us, Alva. They're middle aged.
Yeah, I think that is being a kid, but that's okay.
Yeah, but you raise a really good point, Norman. We've been thinking about how do we get to more of the folks, not to say that the stakeholders that we surveyed weren't important. They absolutely are, and we really gained a lot of insight from their input. But we've been thinking about what are some of the touch points that we can do throughout the decade that helps us understand if the priorities that we're focusing on are relevant to other people, right? So we have this sample that is mostly identified as white. Would it look different if we sampled folks that are largely Hispanic or largely African American or Native American? And I love the idea of figuring out how to pull patients. I don't know that we've figured that out for a national level kind of thing. We're really good about secondary data analysis that is nationally representative, but in terms of getting to patients at a national level in a survey, we haven't. I don't think we've quite sorted that out just yet. So if you have suggestions, please feel free to send that to us. But it's a great point. And you didn't miss it. We just didn't include
Okay,
it. Mhm.
thank you.
So if anyone has, oh, Tammy has a question, please go ahead.
Hi, thanks. I had a quick question because I know that it entered in as number 20, but did you get any other additional feedback on chronic pain entering the list? Because essentially, like, I know that when I've had students coming in, previously when I was teaching in a graduate program for MHA, I had a lot of students that would say their why for why they were going in it because they had the experience of their parent trying to get treated for chronic pain and understood the complexity of like when they tried to go to one system versus being bounced to another system that gets so heightened in rural areas because essentially you don't have those specialists up there. And so I just wonder if you had any additional, I really appreciated the chapter that you included, but if you had any additional feedback of like whether that was more connected to opioids or and then linked in with addiction or any other sense of that part of it.
Mm. Yeah, that's such a good question. My sense from the team that worked on that chapter was that it was driven by opioid use. And in fact, one of the lead authors, if I'm not mistaken, is an addiction medicine physician who really honed in on that. I think that's what mostly drove that particular priority area for stakeholders. And I think you're absolutely right. It's all linked to the addiction, substance use. That team really went into detail about those connections and how that has evolved over time. I remember meeting with that team, and one of the nurses said, in the 90s, we were prescribing opioids like it was candy because we weren't aware that or we were told that it did not have any addictive properties. And boy, oh boy, were we absolutely wrong about that. So I think that chapter really did a deep dive into how that evolved and how that came to be, and chronic pain is somehow tied to that.
We got time for one more question.
What role do you think academia should play in this regard?
Marie, do you want to do that, or should...
I think we can tag team on this,
Okay.
because Gwen, that's it's a small question, but it has a huge answer or huge implication with it. From a School of Public Health perspective, one of our charges is the betterment of our community. So we have an obligation to better understand rural communities and their challenges to access healthcare, of which Rural Healthy People 2030 helps kind of set our agenda framework and history, if you will. From our perspective as faculty who are educating the next generation of scientists, making them aware of this is important. We also recognize that it, much like within MHA programs or broader health administration programs, rural healthcare is not everyone's cup of tea, but I think they need to know this regardless. And then I think the third piece will be working within our state or broadly our rural healthcare community. So thinking specifically within Texas, our program has very strong ties to the Texas Organization of Rural and Community Hospitals, TORCH. So making sure that we have a voice at their table and they have a voice with us as well. Alva, do you want to add to that, please?
Yeah, no, that's perfect. And I think one of the things that as the current director I've been really trying to do is to have those open lines of communication between the boots on the ground, the policymakers, getting the students in on the conversation too. We routinely, when we have calls with HRSA or calls with the State Office of Rural Health, etc., I always try to make sure that there are graduate research assistants who are present and on the line to hear what those conversations are like, so that we are not creating research projects like pie in the sky things, but we're doing things that are relevant to what Austin, I'm using Texas as an example, but what Austin folks need to know and need to push for in legislative sessions, etc. But also what would be helpful to practitioners. So I kind of see us as a liaison between research, practice, policymaking, and as Dr. Cote correctly noted, training the next generation of folks that will be interspersed in these various places of employment.
And sort of building on that, Gwen, if you do it and you do it well, and I see if you look in the audience, there's Mr. Jack Buckley, who is our interim program director for our MHA program. Hey, Jack. What happens is that we have rural providers that come to us and say, we need help in administration. We have a practicum opportunity. We have a fellowship opportunity. We have an employment opportunity. We know your students are appreciative of our communities. Who would you recommend with it? So I think it's a sort of four-pronged thing that Alva and I said is what can we do? It's not for every program, it's not for every school with it, but it's become the nature of what we do.
Well, Mary and Alva, once again, thank you very much. I want to thank you for two things. One of them is the opportunity to present this to everyone, and for Cami to be able to kind of blast it out to people. But I think more importantly, I just want to thank you for your work on behalf of people in rural communities, and in trying to kind of improve the life and the health of those people in those communities. And very much appreciated. And for those out there, again, I feel like I'm pushing a book, but get a copy of Rural Healthy People 2030. It is an exceptional piece of work. And again, thank you very much for being part of it.